This is Dr. Michael Trainer. I have prepared this video today to discuss risks and complications associated with total hip replacement, also known as total hip arthroplasty. In addition to discussing possible risks or complications associated with the procedure, I will also answer frequently asked questions as well as review instructions and expectations for patients prior to their surgical procedure. In terms of risks or complications associated with total hip arthroplasty, the first risk that we discuss with patients is the risk of infection. Infection is a risk for any surgery because the greatest deterrent to infection is intact skin, and when we make an incision in the skin, that is a way that bacteria could infect tissues. If an infection gets into the replacement parts, it is very difficult to eradicate the infection. In order to kill bacteria that causes infection, we give patients antibiotics. The antibiotics can be taken orally by mouth, or they can be taken through an IV line. And the antibiotics will then get into the bloodstream and they will travel to the site of infection and eradicate the bacteria. The difficulty with joint replacement is that the bacteria is smart enough to latch itself onto the replacement parts. The replacement parts are obviously man-made, and as a result, there are no blood vessels that go to the parts of the replacement. And for this reason, the bacteria cannot be eradicated if it latches itself onto the replacement. As a result, if a patient gets a deep wound infection that infects the replacement needs to be removed, which means the patient will need to go back for a second surgery to remove the replacement. At the same time, the patient is then going to require IV antibiotics for up to 12 weeks and also will need to be seen by an infectious disease specialist to monitor the antibiotic regimen as well as laboratory results to make sure the bacteria is eradicated. When the replacement is removed, a spacer needs to be placed because you cannot remove the hip replacement and leave it with nothing. So the spacer is made of cement, and when the cement is mixed, it's mixed with antibiotics. This is how then the infection can be eradicated because the spacer actually has antibiotics attached to it. The spacer remains in place for approximately 12 weeks while the patient is taking antibiotics, and then the patient needs to return for a third surgery to remove the spacer and place the definitive replacement. Needless to say, this is quite an ordeal, and for this reason, infection is one of our major concerns. Infection is very rare, less than 1%, and in my experience, I have not had patients experience deep infections to joint replacement. If a patient did develop such an infection, the steps I've just outlined would actually not be performed by me because I would send the patient to what's called a joint revision specialist. This is an orthopedic surgeon who replaces replacements. And thankfully, I have not had to partake of any of that type of a treatment for any of my patients, but it is certainly a risk. In order to prevent infection, patients will receive IV antibiotics during their surgical procedure. We do not need to send you home on IV antibiotics. Our sterile techniques during surgery and the IV antibiotics that are received during surgery are adequate to prevent infection. And again, it is a very, very rare complication. If a patient is concerned about infection, we always want the patient to call the office after surgery with any concerns. If the patient needs to be seen in the office, they will be seen that day unless we are not in the office, and they will be seen the soonest time possible. After the hip replacement, we expect the skin to be warm. We expect the skin to be somewhat red and irritated. That is not uncommon, and that is not a sign of infection. Also, there may be some drainage from the incision site after the hip replacement. This is also not uncommon. The concerns would be severe and progressing pain after the surgery. that would be the greatest concern for infection. Especially if for the first day or two the patient is progressing well and walking well, and then they start to experience progressively increasing pain symptoms. Again, a small amount of drainage after the surgery is not uncommon. A significant amount of drainage would be more concerning and would warrant a phone call. If a patient has a concern for infection, we do not want you to go to the emergency room. We would prefer you to, again, call our office immediately. Day or night, it does not matter. Weekends, it does not matter. After hours, if it's weekends, the paging service will call me and I will call you. If I am not available, which would be very uncommon, my physician assistant would also likely give you a call to discuss the concerns. If it was a weekday and we were in the office, you can just come to the office if you have any concerns. Again, this is a very uncommon complication, but it is one that we worry about significantly. Again, I will reiterate, do not go to the emergency room without speaking with me first, because unfortunately, many times patients will go to the emergency room and the provider will say that the skin is warm and red and there's some drainage, and therefore they will tell you that you have an infection when in fact you do not. And as I've just discussed, when a patient's told they have an infection after the possible course that would need to be taken, they can become very distraught, and we do not want that. The second risk we discuss with patients, a blood clot after hip replacement surgery. A blood clot occurs in the veins, and this is called a deep vein thrombosis. The signs of a blood clot are significant swelling along the entire leg. The blood clots usually occur in the calf of the operative leg, but it could happen higher up in the leg, and very rarely it could happen in the opposite leg. Swelling after hip replacement is extremely common. Oftentimes patients will have what's called compression stockings or hose placed after surgery, and we usually recommend those be used on a daily basis throughout the day for up to 1 to 2 weeks after surgery to decrease leg swelling. The leg swelling is in part from the trauma of the surgery. It is in part from the fact that obviously after a hip replacement surgery, patients are not jogging and walking the way they would normally walk because they are recovering from the surgery. Walking is the best thing to help circulation, which will decrease swelling, and for these reasons, swelling is very common. The TED hose or compression stockings will help decrease the swelling. However, if the swelling becomes quite pronounced along the entire leg and the patient experiences severe calf pain, this is a sign that there could be a blood clot or DVT present. The concern with a deep vein thrombosis is that if the blood clot travels from the leg to the heart, that is what's called a cardiac embolism, or if it travels to the lungs, it is called a pulmonary embolism. Cardiac and pulmonary embolism can cause death. So for this reason, it is a significant concern if a patient develops a blood clot. This is why any concerns for blood clot should warrant an immediate phone call to the office as soon as possible. And in that instance, we will often send you either to the emergency room or to an imaging facility to obtain an ultrasound of the leg. The ultrasound will then show if there is in fact a blood clot. If there is a blood clot, then the patient will require what's called DVT prophylaxis or DVT medication to thin the blood. So these would be blood thinner medications. Those medications will then be managed by the primary care physician, and oftentimes the patient may need to stay on the blood thinners for 6 months or longer. We do not routinely place patients on prescription blood thinners after hip replacement. However, we do place patients on 2 81 milligram baby aspirin a day for 30 days following hip replacement. Now, if the patient is normally on blood thinners that are prescribed by the cardiologist or the medical doctor prior to surgery, we do not need the patient to take the baby aspirin. We just recommend the patient resume their normal blood thinning medication. However, if a patient is not on blood thinners normally prior to surgery, then we recommend 2 81 milligram baby aspirin taken once a day for 30 days to prevent blood clots. In addition, we recommend the compression stockings. The last thing that helps prevent blood clots is walking. So after the hip replacement, we want patients to walk at least 5 minutes 4 times a day, getting up, using their walker if they need it, and walking in the home, walking outside, walking on a treadmill. Other risks we discussed during total hip replacement include injury to the sciatic nerve. The hip replacement incision and surgery is performed on the back side of the hip. When we perform the hip replacement, we will see the sciatic nerve. Every time we perform the hip replacement, we see the sciatic nerve. The sciatic nerve is a very large nerve. It's the second largest nerve in the body next to the spinal cord itself. And there is one on the right side and one on the left side. The sciatic nerve is about the size of my index finger, so it is very evident and obvious. We protect the nerve during the surgery. However, the nerve is very sensitive, and there is a very small incidence where patients after hip replacement could have an injury to the nerve. The injury could result in leg numbness or tingling, but the most common finding is weakness that causes a foot drop. And what that means is when the patient walks, the foot tends to drop or drag, and the patient has difficulty raising the toes. This can make it slightly difficult with walking as the toes may drag. If the patient develops this, we'll often obtain what's called an ankle foot orthosis, which is a special brace that fits in the shoe to help prop the foot up when the patient walks. I have had, I believe, 2 patients over the years experience a foot drop. Unfortunately, it is typically permanent, and thankfully those patients were able to walk, but they did have the weakness in the foot. The hip pain is typically resolved from the surgery, as would be expected, but this is a complication that can happen, and it is most often permanent. Other risks of the replacement include the risk of leg length discrepancy. And what that means is when the surgeon performs the hip replacement, we try to match up the leg lengths so they are equal. At times, the leg lengths might be slightly off. If that is the case, the body will usually adjust within 6 to 12 weeks. If there is a significant leg length discrepancy, then we can often prescribe a small shoe lift if it is needed. Oftentimes, with a hip replacement, the affected hip is slightly shorter than the other hip because as the ball and socket arthritis increases, it tends to slide upward, and so oftentimes the affected hip is shorter to begin with, and the patient may have accommodated that over many years. So if we make the leg lengths equal, it might seem somewhat off for the patient, and for this reason we give the patient some time for their body to adjust, and it is very rare that the patient would need a shoe lift. Other risks we discuss are dislocation of a hip replacement. When a hip replacement is placed, there is a risk that the replacement can dislocate. Dislocation is also very uncommon, and it is typically associated with certain extreme positions, which the physical therapist will discuss with the patients in terms of what positions to avoid. However, briefly, those positions typically include flexing the hip, which would be bringing the knee almost to the chest, which flexes the hip, and then rotating particularly outward. This is not a position that many people would get into. However, I explain to patients if they were squatting down as if they were playing catcher for a baseball team and then tried to twist, this is not a position that we would like you to be in after a hip replacement. When patients have a hip replacement, they will wake up with a pillow between their legs, and their legs will be straight and separated. It is virtually impossible to dislocate a hip replacement without, again, bending the knee and crossing it over the other leg. Now, with that said, many patients will sleep at night on one side or the other, and they may somewhat bend their knee and cross their legs. We test this position during surgery to make sure that the hip is stable in this position. However, we do suggest having a pillow between the legs and trying to keep the legs relatively straight for at least 6 weeks following surgery to allow for tissue healing and prevent the risk of dislocation. If the hip dislocates, the patient will not be able to get it back in place and they will not be able to walk. You will have to call the ambulance and go to the emergency room. The emergency room physician can usually relocate the dislocated hip replacement in the emergency room. If that is not possible, they will call me and I will come to the hospital, and if I cannot relocate the dislocation in the emergency room, we would take the patient back to surgery. This is also extremely rare. I can't remember the last time that this has happened for one of my patients. It's certainly been over 5 to 10 years, but it can happen. With that said, a patient could have a fracture of the femur or thigh bone either during the surgery or in the future. If there's a fracture of the femur bone during the surgery, then additional steps may be taken during the procedure to stabilize the broken bone. Alternatively, if a patient sustains a fracture or break to the femur or thigh bone or the socket, which is the acetabulum, in the future from trauma of some sort, will typically require additional surgery not only to fix the broken bone, but if the prosthesis or the replacement becomes loose, it may also need to be changed and revised. And depending on the severity of the injury, it may not be a procedure that I perform, in which case the patient would be referred to the appropriate provider. We always tell patients after a hip replacement, the incision site may, once it's healed, may always be a little warm, may always be a little swollen, but that is not infection and that is not necessarily uncommon. Does that happen always? No, but we do not want patients to be alarmed by that. The fact is, when we replace the hip, we are putting in additional parts that were not there previously, and those parts do take up space, which means it could look a little bigger or a little more swollen than originally, but that does not mean that there is any problem, and it may be something that the patient just needs to get used to and live with. Going back to the risk of infection that we discussed, one last point we would make is, while the greatest risk for infection is in the early post-operative period while the wounds are healing, patients could develop an infection to a joint replacement, hip replacement in this case, even many years after the surgery is performed. Some patients might ask, how could this happen? The answer is, anything that could cause an infection in the body could, if the infection or the bacteria got into the bloodstream, it could then go to the hip and infect the hip. And again, what would be the sign? The sign would be severe pain, meaning if a patient had a hip replacement and in 2 years after the replacement all of a sudden experienced severe hip pain that was not getting better, that might be a concern, especially if the patient, for example, had a recent urinary infection or a pneumonia. Or another very common source would be if a patient has a dental procedure where a tooth is pulled, there is significant bacteria in the mouth, and if a tooth was pulled and the bacteria got in the bloodstream, it could make its way to the joint replacement. If a patient has a dental procedure where teeth are pulled, for 2 years following the hip replacement surgery, the dentist will typically place the patient on antibiotics before pulling any teeth. This is not for a typical teeth cleaning, but if a tooth needs to be pulled, the American Academy of Orthopedic Surgeons recommends 2 years of antibiotics following a joint replacement. And this is something that the dentists are well aware of and they would discuss with the patients. Those are the main risks and concerns we have with joint replacement. The hip replacements are performed either in the surgery center or in the hospital. The vast majority of patients undergoing hip replacement will go home the same day. Alternatively, some patients will need to stay overnight, and that can often be accomplished at the surgery center or certainly at the hospital. It is very rare for patients to require more than one overnight stay following a hip replacement. The patient who is having the hip replacement will typically receive a phone call the day before this procedure. The surgery scheduler will give the patient the instructions in terms of what time to show up for the procedure and answer any additional questions. If the procedure is being performed on a Monday, that phone call will come the Friday before the Monday surgery. And again, it may be later in the day because the surgery schedule is finalized usually late in the afternoon the day before the surgery, or if the surgery is on a Monday, it would be the Friday before the surgery. We will see every patient in a pre-operative visit prior to their hip replacement. That's usually about 5 to 10 days prior to the procedure. We tell patients that they should not eat or drink anything after midnight, the night before their surgical procedure. The surgery is done under general anesthesia, and when the general anesthetic is performed, the anesthesiologist will cancel the surgery if the patient has ate or drank anything prior to midnight the night before, because of the risk that the contents in the stomach could come up and be suctioned or aspirated into the lungs, which can cause pneumonia and problems. So we tell all patients nothing to eat or drink after midnight the night before surgery. There is one exception to this rule, and this is if a patient is normally on blood pressure medication that they take in the morning. Patients can take the blood pressure medication with a small sip of water the morning of the surgery. Now that is only if they normally take the blood pressure medicine in the morning. If the patient takes the blood pressure medicine later in the afternoon, it will be given to them at their regularly scheduled time after the surgery. All other medications are not to be taken. This includes any type of blood thinners, any anti-inflammatories, any diabetic medications. They should not be taken. Especially diabetic medication, because we are not allowing the patients to eat and we do not want the sugar levels to drop below safe levels. So the only exception is blood pressure medication in the morning with a sip of water. With regard to the surgery itself, I will see the patient the morning of the surgery. When we see the patient, we will specifically mark the surgical site, meaning if the patient's having a right hip replacement, we will write our initials and put a big yes, because we will not perform surgery on the incorrect side. This is not because we don't know what we are doing, but we have a specific system of checks and balances to make sure that we do not do anything that we do not intend to do for the patient. I will personally speak with family members that are there the day of the surgery. We will obtain appropriate contact information, so I will call the family members after the surgery to report on how the surgery went and that there were no complications or problems, and let the family know what the next steps are to expect. Patients will typically remain in the recovery area for approximately 1 to 1.5 hours after the surgery. The surgery itself usually takes between 1 and 1.5 hours. Of course, sometimes it takes less time and sometimes it takes more time, so it will take as long as necessary to perform the procedure safely for the patient. Once the patient is recovered adequately, we will get the patient up and start walking. Patients can walk with their full weight on the hip replacement within 1 hour after the surgery. As long as they are awake and alert, we will get them up. The hip replacement will support them. They have nothing to worry about. They will have some discomfort from the surgery. Oftentimes we, in addition to the general anesthesia, may use some local numbing medicine to help decrease any pain. Patients will often need to use a walker for assistance initially, and as they get stronger in the post-operative recovery period, they will hopefully be able to graduate from the walker to a cane to no assisted devices. Again, if the patients are doing very well, the vast majority will be able to go home the same day. The criteria for the patient to leave the hospital, whether it's the same day or the day after the surgery, is very simple. Number one, we need to make sure that the patient's pain from the surgery is well controlled with medication they can take by mouth. We cannot send the patient home with IV pain medication, so pain needs to be adequately controlled with oral medication. The second criteria is that the patient does not have any complications following the anesthesia. If the patient's heart rate or blood pressure are not stable, then obviously they will not be discharged. If the patient has significant nausea or vomiting or is just feeling very sick from the anesthetics, that needs to be controlled and resolved prior to discharge. The third criteria is that the patient is safe with mobility. What does that mean? The patient does not need to jog around the hospital. The patient needs to be able to get up and out of bed with minimal assistance. Now, that does not mean they can't use a walker, but they need minimal assistance to get up and out of bed. The patient needs to be able to walk through the hallway with the use of the walker and with minimal assistance. The patient needs to be able to go up and down several stairs safely so that if stairs are required at home, the patient can maneuver the stairs. The patient needs to be able to get in and out of the shower and on and off the toilet seat. These are the types of activities, mobility-wise, the patient needs to be able to achieve to be discharged. With regard to the incision is on the side of the hip. It typically measures about 3 to 4 inches. We close the incision with staples. We typically put a waterproof bandage or dressing over the incision. Patients are allowed to shower the day after the surgery. We do not want patients to use bathtubs, hot tubs, or swimming pools or immerse the wound, but a shower with running water over the waterproof bandage is fine the day after surgery. Again, patients may have a small amount of drainage. That is not anything to be alarmed by. The reason for the drainage is when we perform the replacement, one of the steps we take to avoid infection is we constantly irrigate or wash out the wound. This prevents bacteria, but we inevitably may not be able to suction out all of that irrigation fluid, and as a result, patients may have some drainage. Again, not anything to be overly alarmed by unless the drainage is copious. With that said, we typically tell the patients that they can keep the waterproof bandage on anywhere from 3 to 7 days. At that point, we do want the patients to remove the bandage once a day prior to their daily shower. With the bandage off, you can get the staples wet. After the shower, we request that you make sure the wound is nice and dry and then apply a clean, dry dressing. We do not want any salves or ointments or bacitracin, just a clean, dry dressing with some paper tape or something that sticks to the skin but does not cause significant irritation. We do want patients to walk daily. I recommend walking at least 5 minutes 4 times a day, starting the day after surgery. I try to make it easy. I tell patients they should walk for 5 minutes before breakfast, 5 minutes before lunch, 5 minutes before dinner, and 5 minutes before bedtime. Now, additional walking is certainly in the patient's best interest because it will speed recovery. It will also help prevent blood clots. But walking for at least 5 minutes, breakfast, lunch, dinner, and bedtime is the very least that should be performed. Most patients will have what's called home health following the surgery. This means there will be a nurse that comes to the home to see the patient probably 2 or 3 times a week to check vital signs and check the wound. In addition, a physical therapist will typically come to the home to provide additional exercises for the patient to do and just to ensure that the patient is safe with mobility and is performing their walking exercise. We do not need the patients to do strength training initially. That is not required. We want you to walk. Patients should make a follow-up appointment at their preoperative visit for approximately 2 weeks after their surgery. We will see patients at 2 weeks after the surgery, at which point we will check the wound, we will obtain x-rays. We will then see the patient at 3 weeks after the surgery to remove the staples. The patient will often be given a prescription at between 3 and 6 weeks for outpatient therapy if it is required. We will then see the patient at 6 weeks after the surgery and at 12 weeks after the surgery. The vast majority of patients by 12 weeks or 3 months are walking without any assistance and have recovered very well from the procedure. Many times the patients will be recovered by closer to 4 to 6 weeks. As far as driving is concerned, the first criteria is that if the patient is requiring narcotic pain medication for post-operative pain, we do not want the patient driving. If the patient took a pain pill at bedtime and did not require any other pain pills and the next day they need to drive, that would be appropriate. But if the patient is requiring regular narcotic pain medication, they should not be driving. The second criteria for driving is that the patient is no longer using the walker. If the patient's using the walker, they should not be driving. If the patient has graduated to a cane or is not using any assisted devices, and again is not taking regular narcotic medication, then they are stable to drive. The last criteria is, of course, that the patient feels safe driving. If the patient has not driven for a week or two following the surgery, it is often best for the patient to go to an empty parking lot, somewhere where they can practice to make sure that they feel safe. We did discuss hip dislocations, so we do recommend patients avoid crossing the legs, bringing the legs up high. If you have to tie your shoes, we tell patients keep the leg flat and bring the chest down, not the hip up or twist or turn, because we do not want dislocation. And these are items that will be reviewed with the patients by the physical therapists. The video that we present today is available on our website, which is AOSMLV.com. Again, that's AOSMLV.com. And you can click on the providers, and if you then on the drop down click onto Dr. Michael Trainer and go to the bottom, you can see this video regarding total hip replacement. Thank you.